Nevi grow from cells that were on the path to becoming melanocytes. A mutation causes them to turn into a Naevus cell instead. Nevi cells aren't melanocytes, they differ in a few important ways. They can multiply, producing clones of themselves. Think Agent Smith in the Matrix films. They don't have the dendrils or arms like a normal melanocyte. Therefore, they become stuffed with melanin and are various shades of brown or black, depending on how much melanin they produce. A bloated brown Naevus cell is usually born at the dermo-epidermal junction, and it sets about cloning itself, forming what are called nests of Nevi cells. Imagine this glass is a punch biopsy of this skin, taking a column of epidermal cells from the surface to the dermo-epidermal junction. Let's fill it with layers of keratinocytes. Introduce a nest of Nevi cells where it now starts producing colonies, which rise up, mixing in with a column of keratinocytes. So long as the nest continues to produce new Nevi cells, it remains visible on the surface. Let me slow the action down to make it more realistic. If this process stops, the Naevus will disappear. Nevi are not a stain in the skin like a tattoo. They are a living and active part of your skin. Why are Nevi called moles? Aren't moles small furry animals that burrow into lawns, creating a mess? Perhaps it's because they cover the skin with raised brown lumps, similar to the marks a mole creates over a lawn. And as for you Americans, just because I have 2 American grandchildren doesn't mean you can take liberties with the English language. I'll be teaching them that a Naevus has an A, thank you very much. This is Morris. He has a large family and the vast majority are friendly and harmless, but there is a darker side to the family. How can you tell the nice from the nasty? I'm going to give you 5 simple questions you need to ask of any potential mole to decide. There are 2 main causes for this mutation to occur, and it's not a straw. One is an inherited genetic tendency. The other is environmental, i.e. ultraviolet light. Each root produces Nevi with different characteristics and life stories. Let us first introduce you to congenital Naevis. These are visible in 1% of babies at birth. The genetic defect triggering their production occurs in the first 12 weeks of in utero life. Most Nevi appearing in the first 2 years of life are still congenital in nature, and because of this, around 6% of people will have at least one congenital Nevi on their skin. These Nevi look and behave differently to the other Nevi we acquire later on, and learning to recognise them is important. Dermoscopy will help you, and I'll show you what that looks like later. Sometimes in life, size does matter. Well, that's what my wife says anyway. And this is true of congenital Nevi for this reason. Acquired Nevi rarely reach 1.5 centimetres in size, being larger and sometimes very large. The larger they are, the greater their risk of developing a melanoma in their lifetime. They never disappear and are with you for life. Does this mean that we should cut out all congenital Nevi from our patients? No. Most are small enough for patients just to monitor, reporting any new changes. The larger ones that are at greatest risk are actually so large they are impractical to remove. My first simple question for you to ask of any potential mole is, when did you appear on the skin? Was it there at birth or within the first 2 years of life? If so, think congenital Naevis. Whom shall we introduce next, Morris? Good idea. Globular Naevis. These are the most common type and develop throughout childhood and adolescence, also being of a genetic tendency. Knowing how they form within the skin will help you recognise them on dermoscopy. The dermo-epidermal junction is a wavy line, but in 3 dimensions, the junction between the dermis and epidermis is shaped more like an egg tray, all except on the face, on palms and soles of the feet. We'll cover those special sites in a later video, but do remember the things in this video don't apply to those sites. Let us now introduce nests of cloned Nevi cells represented by these eggs, which is appropriate because eggs are found in nests. A young Naevus will have many of these Nevi nests starting life together at the dermo-epidermal junction. Look at these Nevi in this 6-year-old child, made up of an aggregate of brown dots and globules. This is one of the important criteria to learn that tells us that this is a Naevus and part of the mole family. Just like congenital Nevi, these are with you for life, but they do change slowly over time. Nevi cells don't have the same strong attachment to the basement membrane that normal melanocytes do, and therefore they slowly drift in their location in time. When they start out at the dermo-epidermal junction, the moles look flat or macular to touch. When seen on histology, these are called junctional Naevi. When part of the Naevus cells drop into the papillary dermis, they are then called compound, because they have both junctional and dermal elements. The overlying epidermis actually becomes slightly raised. As they age further, the Nevi cells drop completely into the papillary dermis and are now called dermal Naevi. This whole process can take 4 to 5 years or more. Therefore, dermal nevi become increasingly common in adolescence and beyond, persisting throughout life. These aggregated globules come in different sizes and shades of brown, but should be similar throughout the whole nevus. When the globules are angulated, we call them a cobblestone pattern because, well, they look like cobblestone paving. Many intradermal nevi, as they age, stop manufacturing melanin altogether and become a lighter colour, even pink, with just some wispy pigment remaining. The aging process results in 2 clinically different forms of dermal nevi, which you need to know, their patterns on dermoscopy being similar. In 1896, a Dr. Paul Unna described what he called a soft nevus. These are found mainly on the trunk and limbs. One survey of 700 people found 1 in 3 people had at least one. They are wobble positive, and this is a key clinical finding that helps differentiate them from a basal cell cancer. The other type is called a Meischer intradermal nevus, named after a Dr. Alfred Guido Meischer from Zurich, Switzerland in 1935. The important difference between Unna and Meischer nevus is that the Meischer type is flatter, it's a smoother dome, and it's wobble negative. A survey of 751 people with these nevi found that 91% of them were on the face, and 94% of all dermal nevi on the face were of the wobble negative Meischer type. You may have noticed I have one here, pink, and it will never turn into a melanoma. A Meischer type intradermal nevus is the most common cause for a PPPP on the face. People with a pink papule problem. If you are just starting out in dermoscopy, being able to tell a BCC, also common in the face, from a Meischer type intradermal nevus is an important skill to learn. Here's my summary list of differences to help you, and my video on BCCs if you've not seen it already. Being able to quickly recognise an intradermal nevus of whichever type is an important skill. How am I doing, Morris? Shall we turn to the other side of your family now? The other trigger for nevi appearing is ultraviolet light exposure. Such nevi are called acquired nevi and tend to develop what's called a reticular or network pattern when viewed on dermoscopy. The lighter your skin type, the less ultraviolet protection you have. Therefore, identical twins raised with 2 different exposure levels to ultraviolet light will have different numbers of acquired nevi. It's also the reason why people with skin of colour have fewer acquired nevi. They have inbuilt ultraviolet light protection. Acquired nevi appear in childhood, grow more numerous in adolescence, peaking in the 30s, then start to fade and disappear by the 7th decade. Although some do transform into dermal nevi, it's rare to find a reticular patterned nevus in the elderly. What causes this reticular network-like pattern? It happens when the pigmented cells aren't in nests, but rather are spread out along the dermo-epidermal junction, a bit like this. As you look down on the skin, the concentration of melanin is greatest on the sides of the retiridges going down than across the top of the dermal papillae, creating holes in the network. Note in this picture how the network fades out at the edges. If you see a network pattern like this, it's a nevus until proven otherwise. As with everything else in medicine, there are exceptions. Some dermatofibromas and sebk's have a peripheral network within them. That's because their basal keratinocytes can be more heavily pigmented than usual. Be aware of these 2 exceptions, but there should be other clues to suggest the diagnosis is a dermatofibroma or a seborrheic keratosis. Skin colour, as you would expect, significantly affects how this network pattern looks. Paler skin will have a paler network. It will even be patchy at times, sometimes with a central pale patch. Also, you tend to get hypopigmentation around the hair follicles, which can cause white patches. Dark skin types will often have a darker network, even a dark central black patch. The second question you need to ask your potential mole is this: are you really a nevus? If you see aggregated pink dots or globules or a pigment network, the answer is yes. These 2 patterns will account for the vast majority of nevus you will see. There are other members of the nevus family identified using other patterns and colours, and we'll touch on those later in this video, won't we, Morris? One question that puzzled me as I was researching nevi is why do acquired nevi decline as we get older and not just keep increasing in number as we get older and accumulate more ultraviolet light exposure? One answer could be we change our behaviour as we get older. Do we? Well, yes. On average, children spend more time outside, and up to 50% of your lifetime exposure occurs before the age of 20. Ultraviolet light exposure on average decreases with age. Also causes solar lentictigos to form, and these increase in prevalence with age. Percent of all over 60s have at least one. Solar lentictigos are not formed by nevi cells, and are therefore not nevi. Morris, are we ready to bring the 2 sides of the family together yet? To summarise, globular and congenital nevi are primarily due to your genetic makeup in origin. Choose your parents carefully. While acquired nevi are triggered by ultraviolet light. Are things really that clear-cut? No. As usual, your genetics interacts with your environment, giving us nevi with a mixed pattern. You can have central globular and peripheral reticular patterns to some nevi, or central reticular with a peripheral globular pattern. However, listen up! Peripheral globules are a very important feature to recognise in any nevus, because they mean that nevus is growing. Here's an example in a 25-year-old lady. The nevus has a developing reticular central pattern, but peripheral globules. Now this is quite common in young people and of no concern, because that's when new reticular nevi tend to appear. However, look at this picture in a 63-year-old lady. Notice the difference? It's a mole she noticed 12 months ago. It's not only got peripheral dots and globules of pigment, but notice they are variable in size and a shade of brown. Be very suspicious of any new genuine nevus in someone over the age of 45. In fact, one study showed in the over 60s, a new nevus had a 1 in 4 to a 1 in 3 chance of being a melanoma. This leads us to our third simple question you should be asking. How old is your patient? Your patient's age tells you what sort of nevi you would expect to see. Is there any other way to help us tell if one of your relatives is nice or nasty, Morris? Ah yes, symmetry is beautiful and beauty suggests benign. What is symmetry? Which of these shapes is symmetrical? Let us now put our dermoscope on these nevi to see their actual patterns. Which of these are dermoscopically symmetrical? Using the often taught ABC rules for identifying a superficial spreading melanoma, many nevi are picked up that will break those rules as being suspicious. However, when you put your dermoscope on them, they have a nice symmetrical pattern, which is more important, and they are in fact benign. This 58-year-old lady came about some recent changes in a mole she'd had on her tummy for many years. It's not symmetrical particularly, it's slightly tan coloured here and pinker here perhaps. You might be concerned. A hair follicle is reassuring, but not conclusive that it's benign. As the patient had noticed new changes and it's evolving, are you confident to call this 100% a nice mole and not a nasty melanoma developing within it? Are you willing to bet your patient's life on it? Now let's put our dermoscope on it. I hope you recognise this pattern now. It's globular with a cobblestone pattern. So it is a nevus. Is the pattern the same throughout the nevus? Well, yes it is. My 95% confidence has now become 100%. Her nevus has just been changing into a common intradermal nevus, and they never turn into a melanoma. Another way to think about this is with pizzas. Consider this pepperoni a globular nevus, and this is a reticular nevus. They are symmetrical in shape and pattern, therefore benign. They are now asymmetrical in shape, but still dermoscopically symmetrical, and therefore still benign. However, what's this? If you unpacked your pizza from the box and found this, what would you do? Something's going wrong here, and you'd be correct. Their shape now may be symmetrical in outline, but the structure is asymmetric, with two patterns, therefore suspicious for new changes of a melanoma. If a nevus has one colour and one pattern, it's benign. Your fourth question to ask is, does this nevus have a symmetrical pattern on dermoscopy? If it has just one pattern and looks symmetrical, it is benign. Our underlying genetic makeup is written throughout our bodies, even when it comes to your handwritten signature. Imagine each of these signatures is a nevus. I'm hardwired genetically with a finger and arm length and muscle and joint power and flexibility. Therefore, each signature or nevus will be unique to me, and it should be similar enough to recognise them as mine. This is called your signature type. What if I now write one with my left hand? Can you pick it out? This is called the comparative approach to picking up a melanoma. It's the basis for the ugly duckling, finding the odd one out. Which gives us our fifth simple question to help you identify a nevus as benign. Is it similar to the patient's signature type of nevus? The way to make this work best is, if someone comes to you concerned about a particular nevus, look at all their other nevi first and work out what their basic signature type is. Only then look at the one they came concerned about. You may find that actually they're very similar, and that is very reassuring. Let's now go back to the small congenital nevus I showed you at the beginning of this video. This 26-year-old lady's story was she had had this nevus on her arm since birth. It had perhaps slowly grown with her over the years, but in the past 3 months had noticed one particular change. Here's the dermoscopy. Don't freak out and switch off, let's decode it together. Congenital nevi can be reticular or globular or a combination. What do you think this one is? I think it's globular. 79% of congenital nevi have terminal hairs within them, and sometimes very hairy. This one is no exception. You will also see milia flashing up on non-polarized light in 52%. There were none here. Note the dotted vessels and sometimes pigment dots within the globules, or if this had been a reticular pattern, within the holes of the network. This is present in around 30% of congenital nevi. Is it symmetrical in shape? Well, yes, it's oval. However, is it symmetrical dermoscopically? No. This area is different, and it's this area she noticed the new changes. This is called a negative network pattern. Add this to reticular and globular as a pattern indicating this is a nevus. A positive network is formed by lines like this. A negative pattern is formed by lines appearing between structures within the nevus. You are most likely going to see this in intradermal nevi within a cobblestone pattern. When it's part of a symmetrical pattern throughout the nevus like this, it's not a concern. When it's asymmetric and new, it can indicate growth and a possible melanoma. For this reason, I referred it on the cancer care pathway. On histology, it was still a benign congenital nevus and not a melanoma, fortunately, but it could have been. The clue was in recent changes and a negative network pattern. If you've made it this far through this video, good on you. So far, these are the criteria to identify a skin lesion as being of melanocytic origin. Early on, I mentioned other criteria, so we'll cover a few of them now because you will see them. Melanin is black in colour at the surface of the skin. It's brown at the dermoepidermal junction and blue or grey when deeper in the skin in the dermis. Some nevi nests are formed even deeper in the dermis. These are called benign blue nevi and they're best left alone. However, just now and then they appear suddenly and other options open up. If there's a past history of melanoma, it could be a skin metastases. Some BCCs are so heavily pigmented they just look blue, enough to cause confusion. My approach has been, if it's new, I refer them on for secondary care to review. These have all been excised and no melanomas or BCCs have been found. You will hear about a reed nevus, pink or pigmented. These are a starburst pattern formed by streaks at the edges. I've never seen one in my dermoscopic career, and if you do, just refer them on. In younger age groups, they're just actively growing benign nevi, but as the age of the patient presenting with it increases, so does the risk of it being a melanoma. And if I see one, I'll be referring. Let's update our list of criteria that tells us on dermoscopy that we have a nevus. There's two things I wish I could give you as you start learning primary care dermoscopy. One, the ability to recognise a SEB-K because they are so common and can mimic so many other skin lesions. The second would be intradermal nevi. This is how the dermoscopy is usually taught. Patchy brown pigment, globules with comma vessels. Why are the vessels comma shaped? It's because in an intradermal nevus, the papillary dermis is often raised above the surface of the surrounding skin. The vessels loop up and down into view, a dermoscope only being able to view to a certain depth, resulting in comma or curved vessels being seen. Recognising intradermal nevus is so important. Here's 4 of my patients to help you get started. This lady has a darker skin type. Note it's wobble positive with uneven pigmented globules which obscure any blood vessels below. If you said it's slightly cobblestone with a network pattern throughout, I would agree with you. This wobble positive Unna type nevus on this gentleman's trunk has a little bit of residual pigment, but note this brown globule is a comedone-like opening. Mature intradermal nevi often have these at times, which can cause confusion with a seborrheic keratosis. However, SEB-Ks aren't wobble positive. Their vessels are usually of the hairpin type. These are much more curved. Note how slightly out of focus the vessels are. This wobble positive Unna nevus has a bit more pigment remaining. The vessels are slightly out of focus, but sometimes they can even look arborizing, which can fool you into thinking it's a BCC. I've never met a nodular BCC that has been wobble positive, and any pigment isn't scattered and fuzzy like this. Note the comedone-like openings on this mature intradermal nevus and a few nice comma vessels. A colleague brought this lady to me for a second opinion. She developed some bruising around a mole on her upper arm. There are 2 nevi. The lower one I hope you now recognise as being globular with a cobblestone pattern and a few short vessels within. This is a typical intradermal nevus. The upper one shows bruising around the nevus, aggregated brown globules within, meaning it is a nevus. They are all similar in colour. I called it a small intradermal nevus, but gave safety netting advice. In other words, the bruising should disappear within 2 weeks. If not, let me know. And just monitor the nevus, reporting any new changes. Here's the 5 questions to ask of any nevus as you consider if it's benign or warrants further consideration as a potential melanoma. But what do you do if you see something like this? Then you have an atypical nevus, and you now need to watch this video here, when I've written it that is, to decide if it's a potential melanoma and what to do about it. Now go and start checking your patient's nevi, building up your own internal picture of benign nevi, globular, reticular, mixture, signature types, like my friends here, Morris the Mole. Training a primary care dermoscopist for every general practice.